Okay, let's get started. Thanks for everyone for joining us today, especially for short notice. This is our special of the special NLP interest group. So today is our great pleasure to have Dr. Erping Long from Chinese Academy of Medical Science and Peking Union Medical College. So Dr. Long and I have been colleagues at NIH. So we have been working some of the AI and genomics in medicine projects together. So, so Dr. Long was also did his PhD in University of Michigan, and then have the postdoc training at NIH. So he's a clinician. He was trained on ophthalmology. That's when we taught together on different research projects. Dr. Long has won several awards, like NIH Fellows Awards for Research Excellence, the NCR Informatics Tool Challenge Award, and other things. So today, he will talk about our recent work for in nurse and also large language model collaboration framework that have been also validated in clinical sites. So let's welcome Dr. Long.
Thank you so much. It's like a happy opportunity to give a talk here. I'm also very honored to be introduced by my friend team. So today we are talking about recent work just published, and we have years of collaboration with Qingyu for outpatient reception, and through the collaboration between large language model, which we call LLM, and reception nurse. So when we first begin, so why we conduct this kind of research? So in our institute, we call them PUMC, Peking Union Medical College. So we have a specific role in the Chinese medical system. So first, so we are a hospital-based, or let's say healthcare provider. So we have the top and the best medical service in China. But also our mission is not only we provide healthcare service to the rich people or governments, but also our mission is to open to all the people. So that's one kind of our mission. And the second mission is we are conducting the medical education. We don't recruit too many students. We are having just around 150 students per year. We're having the 8-year program or 4+4-year program. And the second part is also we are conducting research, and that's the most important reason that we choose to using the LLM-based more medicine. Because what we are focused on, it's not just a specific question, but also in the whole Chinese medical system. So what kind of innovation can just drive the whole country system into another level, or just have a transformative shift to what current challenge they have. So let me show you some facts about the current medical system in China. It's a kind of different from Western countries. So first, unlike Western countries, so we have in Western countries we have like primary hospitals and many qualified or very top level physicians. They can provide healthcare services in that kind of practice. But in China, so most of the high quality medical service in government-based hospitals. And the second thing is, so because we are lacking very high coverage, family-based doctors, and also community-based service. So all the people, they are willing to come to the healthcare service in big cities. So we know there's a Beijing, Shanghai, Guangzhou, Shenzhen, so things like this. And because of this, so hospitals in China, so those large hospitals, they're pretty large, like thousands or even 10,000s of staff. So they are within this site. And they are covering the whole, like the whole city, or even the whole province. So then all the patients, even they don't have like very severe illness, but they would prefer to go to the large hospitals, even take dates, and then waiting for a long line. So that's the current status of Chinese medical system. And the other thing is, because those hospitals, so they are government-based, which means, so some of them, like they are, we call them like federal employees, so government employees, only a small size. So we call them core faculty. So they are stable, they're relatively highly paid. And then, so they can like working for years and they will not be fired. But most of them, other people, other than the physicians, so most of the management staff and supporting staff, so things like this. So people like this, so they are lowly paid and they are like unstable. That's the status of the Chinese medical system. And so we, in this research, so we are focused specifically on the healthcare management. Most of people, they are more taking about, so they are like two costs of a hospital. So one cost, we call them direct costs, which like we are providing drugs and we are performing surgery, and also the cost for paying our physicians. So that we call it direct cost. It's directly relevant to the treatment and the healthcare activity. But also there's another part, we call them management budget. That's helping the direct cost of the medical activity to go in smoothly, go in efficient. So that part, as we can see, so in US public hospitals, it's around like 25%, it's not a small number. And even some parts in Scotland, so it's like around like 12%. So that's also, so although it's like not that large for the direct part, but also a substantial and a large part of the cost. And in China, so we have something we call them red hat documents, which is be issued by high-level governments to tell them what's specifically for the high-level challenges of the healthcare service. And then overall, so it's we know, okay, our efficiency and our cost is high, our efficiency is pretty low. And there are many limitations in our current system. Even we don't have the like cost calculation or accounting system. So we even don't know what's the number, like what percentage that we have, but we already noticed, even the government noticed. So that's a huge problem that we have to address. Specifically in this research, we are focused on outpatient reception. So that's, we think it's a front line, the medical management. Let's be very specific with what reception nurse is doing. So when patient like come to a hospital, so you have to first recept them. And then they may tell them, so what's my purpose? Like I want to see a specific doctor, or just I'm very painful in my stomach. So what should I do next? So that's like a guiding or triaging, telling people what to do next. So that's one role. And the second role is, so during this process, for example, you come to see a doctor and the doctor give you suggestion of a treatment plan. like you have to go to another room for examination. You have to go to another place to have some drug, or you have to transfer to another department for another like diagnosis, things like this. So then you have to go to second step, third step, fourth step. And during that, you have to use some process, registration, some documentation, things like this. All the things happen during this process. Then people may have concerns or they have questions. Then they turn to the reception desk. So in a large hospital in China, so like, for example, we have a 10-floor buildings, then different departments, they are located in different places. So that people like working around and then towards different directions. Then they have questions, then they turn to the nearest reception desk for their specific queries. But in China, so reception is a nurse, unfortunately, so they are not core facilities. So that's how usually how people manage this thing. So first, they are all contractors. And then in China, so all contractors, so their payment is relatively low, or let's say very low. And the second thing is because of the payment, so you cannot have very professional or receiving like long-term medical training people to like apply for this job. And also, so then the standardized training for those are usually relatively short. So most of them, when they are starting their job, so they are unqualified. And the third point is also why that's a very short-term training, because of the low pay and unqualification. So that's a very high turnover rate, which means so many people, they just take this job as a transition. So they are not, most of people, they are not satisfied with this. They just have a temporary one, and then I maybe switch to another one that I'm satisfied. But that's also why there's a short-term training. Because if you take a loan, then you make a loan, which you invest in, and then people change their jobs. So that's the status. And to like deeply to know about what happened to the reception desk and what's their job and what's their status for their nurse. So we initiate a real-world medical dialogue associate, which means we're trying to capture all the conversations happened at specific sites. So for example, so that's a specific like reception desk. And then different like people like when they arrive there, so they may have specific questions, then they will ask different questions, whatever. And then, so that's the reception nurse. Then we will put some audio record here. When they start their working, for example, 8 a.m. at morning, and then they will end 6 or 7 p.m. So then the whole working process, so we have all their role conversation data. So that's what we call real-world medical dialogue. So that's something we start last year, and then we keep doing this. In this research, we using the data for 2 medical centers, and there are 10 different reception sites. And so that's over nearly like 40,000 minutes, and that's nearly 35,000 cases. When we call cases, it's one patient, and then they ask their questions for one nurse, and they make just one round and they address, or they can be multiple rounds. So that's we call one case. And just we having the new data. So now we have more participating centers. So now we have 5 centers and 24 different scenarios or sites. And we are now having over 1 million cases. So they can be used by future research. What is the meaning to collecting this type of data? It's like, so first we just looking at our real data, we have several statistics that we think is interesting. So first, because we know when they end, then we can count it, for example, how many cases or how many consultations they can be handled per hour or per day. So that's the number we have on that average, which means one nurse. So even 1 minute, so they have to handle 1 cases. So that's very highly workload. And so this number of words, meaning that when they begin their words, maybe 8 hours or even over 8 hours, they are always speaking, addressing different kind of queries.
58.6 is the hour, hours per week, or
Which one?
you say the 58.6 hour consultation hours, that's
Per hour.
per hour.
Yeah, per hour. So then, so each hour we have.
Each hour they actually talk to almost
1 minute.
patient
Yeah.
per minute.
Yeah, per minute. So that's the statistic that we have. And because we knows what happens, we knows how they ask and how they answer, then we have 2 events that we observe. First, it's so when the viewer talking, so for example, patient, they ask for one specific question. Then they may get answers, but they are not understand each other. They may ask again. And then the nurse, they can be answer again. But that's we call them repeated Q&A. That's telling actually they talk, but they are not communicating well. So that's inefficiency communication. So that's over around 14%. The second thing is negative emotion, even in the text or in audio, your voice change, or even you say something to express your emotion. So negative emotion, the percentage is 7%. So that's showing relatively or comparing to the curated medical Q&A data set that now we have many different type of the open access data. This type of data, they're showing how busy, how noisy, and how complicated when real world conversation happens. For example, so now we're talking about repeating. And the second thing is, it's not like I say, I finish my queries, then people answer. Still about interruptions. For example, I say just half of my questions, then they jump into a answer. And the answer maybe is not exactly or directly answering one, but just pinpoint to another thing. That's your dialogue, your conversation. They are very likely starting from one direction, and they keep change, and then go into another unpredictable direction. So that's the value showing the capacity of conversation. And we can test whether LLM or different AI technology they can handle this or how to handle this. So that's how we think the difficult situation, the nurse that we have. That is, we have a too high requirement for those nurses. They are not trained very well. They are not paid really high, but they have to work tireless. And when they are providing their response, they have to be very professional, and also they have to be emphatic. They have to also show kindness or just to comfort the stressfulness of the patient that they have. But they are human beings. How could they work like this? So that's, we ask whether the LLM or AI technology, they can help with that, at least to address those redundant and easy kind of queries. Just leave those difficult ones, or some only a small part that can be addressed by human beings. The overall, we call our techniques spike. the overall philosophy we think is like kind of different from the general AI or LLMs. So the basic word, or we call them backbone words, like GPT-based or Llama-based. So they are like inputting for all kinds of resource. So they are able to handling different domain or different general queries, but they are not specialized in specific situation. But we believe, so let's say the general LLM like GPT, so they are facing the big words. Big words, they are consist of different components and roles. So they are good at knowing all the things. But the big words is consist of different like small words, like different contexts. Within specific context, the roles, principles, and knowledge that required is very specific. Then we can show something later. But given a context, for example, all the people, they are going to the 6th floor of a specific hospital. So they are maybe all approaching to a specific department. When they arrive there, the concerns that they have is limited because they are the same type of people and then into a same type or similar type of context. Then their queries are very specific. So the key points when applying the LLM in the specific context, it's to curate what knowledge and what principles that should be applied in that context. Then we develop the context-specific word, and we have a specific implementations or collaboration word then can be embedded like into the current work, make it work. Here, panel B is showing, so we have 10 different sites. So here, those 4, so they are one hospital, we call them one center. And here, the later 6, it's another hospital. So most of them, so we put them right here. So that's purple color. So purple color is like, that's the common knowledge that's shared. Like it's not context specific, and yellow ones, so they are like can be shared within a specific center. But most of them that in green colors, so they are very context specific. And we develop a series, but it's not like an innovative of techniques to like using those acknowledgement help to respond those lectures. And we can show later that how we can alert those unsafe or uncertain response. So first observation, we divided into training sets to curate our knowledge. And then part of like 20%, so the independent sets for internal validation. The first observation that we have is we can simulate whether, so for that queries, so what's our LLM response? And we can see, so they can address the comments in smaller rounds or fewer rounds, which means, for example, for human beings, they may go for 4 or 5 rounds, but LLM, they can address, for example, 2 rounds, which means the improved efficiency. The panel C, it's not like a classic, for example, classification algorithms. We can talk about accuracy. So now you are talking about generating a specific, for example, a paragraph for the context. It's not only about correct or incorrect. So then they have a different matrix. So that's the 6-dimensional matrix that we have. Whether the factuality, whether you're saying things that correctly, and whether, for example, to respond to this queries, you should have like, for example, 4 points, whether you already captured all 4 points. And then, so you can provide factuality, you can provide facts, but whether you say something to comfort those people, so we call them empathy. And also, you can say a very long paragraph, so it's very difficult to understand. So whether it's the readability, whether it's good. and also about safety, which means if the patients, they followed your contacts, then whether they can suffer from some specific risk that people care about. So within those 6 dimensions, all our LLM models, so comparing to the human nurse, so we have a comparable or even better performance, especially for the empathic part. And here is panel E is showing, so even within the reception desk, so they have a different type of queries. So for example, triaging, pinpoint people to different departments. Primary care, when they receive specific prescriptions, so they may have different concerns. So why I have to take this? What's some bullet points that when we use this, so what should I care about? So in primary care cases, and also for administrative, we think that's very easy, but that's very like noisy queries. Even within here, so I want to drink water. So how could I find something or restroom, or when I register for another appointment, and then they may have an app, and then they go through multiple steps, but some steps that are like confusing, so people cannot go through. And so within our system, we have like fine tuning and also prompt tuning, and to like feed our curated knowledge into the model. And we kind of show that, so different components, they're contributing to different performance or like different dimension of the performance. And also we obviously we observe that, so comparing to the original backbone one, we use GPT 3.5. So nearly all performance we kind of improve. So that's showing the value of our framework system. And also here, so that's asked by one very interesting point. So some scenario, for example, when you're training the nurse, so you have a kind of SOP or standard procedure something. So why you just directly using them, but you collecting the audio and then you transform into the text and then curate into knowledge and then using that. So that's like lots of efforts, right? So why you not just specifically using the established pattern? So we tried using that to feed out that. The performance is okay, but factuality and integrity, like. And then we're going back to see what difference between our created knowledge and standardized guidelines. Standardized guidelines is based on experts or some experienced people based on their memory or their experience, and then they make bullet points. For example, 1, 2, 3, 4, 5, 6, it's like a handbook. But in specific context, so the queries or questions that generated by people are unpredictable. For example, you go through this app, so they have a 6-step, and within this SOP, so they have a general introduction. Okay, that's 1, 2, 3, 4, 5, 6. But maybe the specific challenge the patient have is in number 4. So the button is like misleading. You point here, but it's not that button, it's another one. So for example, in red color. So that kind of like a queries or acknowledgement is like neglected by the human-made guidelines. So that's one scenario, and we have many others. Another part is we all know that as a hallucination or mistakes or unsafe generated context for error. Because we curated that knowledge, that's we can say like a reference or ground truth knowledge. Then we can use different type of like RAG or independent mode evaluation, or like even the key phases statistics. So we know, so within our training data or validation data set, though for some context they generated are wrong or low quality, then what's the high frequent observed words that within those low quality response we can generate them, and they can be specific using as a ORT signal to notify the unsafe generation.
Last question about this evaluation. So do you have a gold standard so you can have compare what large language with the gold standard, or you actually have a large language generate, then you have a professional actually read their generation, trying to rate it? Like how exactly the evaluation is done?
Yeah, very interesting point. So let's say one by one. For example, so this one, so we have 3.5, then we can have an independent mode, for example, 4.0. So we can evaluate whether your generation it's correct or not. So that's one part. So they have definitely some specific threshold or cutoff to define whether it's unsafe or safe. And so here, this part, so we have a reference, we have the knowledge, right? Then we can see whether your generated response is just based on maybe one or two knowledge that we created or just made it by themselves. So that's another part.
How do you judge? You use a ChatGPT to judge the machine generated answer versus knowledge, or you have human actually judge it?
We don't involve human because that will not be employed in real world scenario. So we use like a similar like RAG model. So RAG model
to find some sources attributed in the responses.
Okay, so it's automatic
For
evaluation.
this one, it's automatic. So back to the previous slide.
Yeah, how about the previous slide?
Previous slide is
you have all
actually
the safety and all those. Those are
that's
manually.
manually.
Yeah.
These are manual.
Yeah, this manually like the 6 dimensions. So we have an expert panel to evaluate that.
How big is the data set for the testing? Like how many people? Thousands of conversations?
Thousands of like good point. So the internal validation, like the data here is like 7,000.
7,000. And how many people to read it and rate it?
We have 6 people. Six people are divided like so 3 are professional. So they are physicians.
So they are the senior one, right?
Yeah, senior one, and 3 are lay person.
Oh, okay.
And the last thing we did, we conduct a randomization, randomized control trial. So that's an independent part for anything that we present before. Because how do you know? So they have many confounding factors to evaluate more. For example, some people they may have a relatively like positive attitude to LLM. Then they think all they generate is good. And also, for example, they have like gender or age, like different, like older people, they may be not that positive, and younger people, they may be more open. So there are many unknown confounding factors. So that's why we have RCT. RCT is like we recruiting people using a specific criteria. So here it's we relatively simple. So we will evaluate whether this patient or people, whether they are able to communicate smoothly. So some people, they have mental problems or they are like, they cannot speak. So we are not involved. So we just making people so they are able to communicate. And then when we recruit this number of people, then we do randomization. Just randomize into one-to-one ratio to different groups. So we have 2 groups. And the first one is, so they will be take care by the spike first. And then we have the alert system. Then alert system would, if they alert, so then the human nurse will involve. Otherwise, so they are purely like AI based. And the other one is like the conventional one. So the human nurse will just take care of them. And then within these 2 groups, then when they include and then when they finish their queries and response, then the trial is ended. And then
It's the interface for the AI one. Like the human is talking to a screen, they go to a computer, they talk to the screen.
Yeah, very good point. So in our scenario, so it's audio to audio. So patients speak first, and then we have an audio to test transformation automatically. Then they will transform into test. And then the test, so go through the LLM, they have the text-based answers, and then we have a standardized speak-out system. So then the patient, they can hear it.
But it's like a Zoom meeting, but it's AI agent on the other side. You ask question, they will answer.
Yes, yes. So in the real world setting, so we have a clinical like coordinator. So that one, it's like first you have to talk with people to say, okay, that's the overall design of this child. So you should understand that. So you are possibly like facing this. And then we will briefly introduce how this works, and then to make people, for example, you speak, you have to near enough for the microphone something, and then they may be coming back in several seconds. So those like a short introduction to make sure so they understand the scenario.
Those are the patient like in the outpatient. In China, it doesn't really matter. It's all go to hospital.
Yeah, but for this trial, because we have 10 sites we mentioned before, but we only select one site. So then when we recruiting people, so we are just so that there will be a place there nearby the site.
Are they inpatient or they are outpatient? I'm trying to. Are they patient within the hospital or the patients that just come to the clinic too?
Yeah, good point. So theoretically, it's very difficult just define the like inpatient or outpatient. But in the context like that, so that's the first floor of that hospital. So there's a general reception desk. So most of them should be outpatient.
Come to ask, see the doctor. It's not the patient stay hospital for surgery.
Yeah. So like maybe very small proportion, for example, inpatient. So they're going through some process, and maybe they just walk by, and if they have queries, but that's very rare scenario. So most of them should be outpatients. But our criteria is whether they come into that specific context, whether they have query. If they don't have query, then we don't recruit them. If they have, the A panel is talking about the satisfaction. So because in internal validation, so we cannot ask the patient, going back to that patient to see whether you are satisfied with the LLM response, that's impossible. But here, when they finish the trial, so they can rate whether they are satisfied with those or not. So that's the primary outcome of this. And so the satisfaction rating for our spike or LLM is significantly like better than. And the second is we not only care about patient experience, but also we care about nurse experience. We want to help each other. And so here it's like we have 20 nurses. So nurses is like we have a rotation plan to try to like they can be evenly like participate in both groups. So the nurse are contribute to both parties, and they have a plan. And so nearly like 95% or even 90%. So nearly all the nurses, so they are very satisfied with this LLM technology to help them. Because actually here the alert rate is like very low. It's like 5% something. So that means nearly like 95% of the response that can be completely handled by our technology. So then the human nurse just need to take care of only a few of them. So that's they are very satisfied with this. And again, so in addition to this dimension, we have still another 5 dimension, and also the impactity. So it's like significant improve. The last thing is here. So between those two groups, so we are coming back. So whether they have some adverse events, whether they have repeated Q&A, Q&R, and whether they have negative emotions. So they have like a 11% drop, or in our LM, and also they have a like 5% drop for the negative emotion. So objectively, so the patient experience and the nurse experience improved. Here is we're showing 2 examples. So the first example you can see when even in the reception desk, so people ask for some specific questions. they have different requirements. For example, here. So they're wondering how the MRI to this examination works. So you need to have at least have some professional knowledge to answer this. But you can see, does it cause nuclear radiation? Is it okay not to do it? So these people, they have some prior preference. For example, they are like concerning about this, and they are thinking about whether I can not doing this. So they have some specific concerns. So then when you're answering this, so the perfect one is you have the knowledge telling people what is MRI. The second one is you have to understand. So when they are asking this, so they have some concerns or some stressful things, then they're talking about, so that's a very safe examination. And so the decision, if you want to make, so we recommend, so you're doing this and just to comfort people. So when you're answering such a, we think that's simple, but it's not that simple.
Sorry to interrupt. So everything here is English, but when you do it, is Chinese or English?
It's yeah, it's a Chinese, it's a Chinese-based word. Yeah, but we
English.
I was thinking you convert Chinese audio to English text.
No,
Chinese
GP is multilingual.
Yeah. So when we're doing this, it's all Chinese-based, but when we publish paper also presentation here, so we translate in English.
Well, next time we can test the English.
Yeah, true.
But so the question is widely open. It's very broad.
Yeah, very broad.
You can ask medical questions or like administration things. Okay.
Yeah, very good point. So I have 2 points to add. So first, all this, so we are not doing any for medical decision. So we are not doing any answering any queries for medical decision making. All it's about after medical decision.
So what if a patient asks something, so you just tell him or her when?
Yeah. So that's something which we do not. So we will, because that's relevant to some safety things. So here we are all, so we define the three type of. So administration, triaging, and also primary care. Primary care, when we already make decision, for example, you take drug A, then you can ask what is drug A and how to use drug A. But we will not say whether it's A or B. So that's something we don't involve. And the second thing is, so although the queries is coming from different, like happened a very wide range, but what we have seen is in specific context, so it's not that wide range. So in that place, so people will have like very specific context. So that's the second one is talking here. So in China, so always there will be a long line. So maybe 20 people or 30 people say they're waiting, beginning from the morning, and then maybe when they see the doctor, it's already afternoon. So people are very anxious about it. Then maybe people like keep asking, when can I see the doctor and how many people are in front of me? And nurse, because they are not the people that can decide this. So they are very like angry or mad about this. So how you can interpret or like answering these questions. So our LLM, so they can tell people why, so what is our procedure to making the line? So what's the rationale, for example, when we decide this principles for the lining, so why we decide that, so that's reasonable. And finally, they can tell them, okay, so please be patient, and we all will care about it, and we make sure so you are in line, so things like this. So that's a and then when we develop this framework, and then so that's how we estimate and we can employ so this technology into real world scenario. So usually for reception desk, so we will take 1 to 2 weeks like audio collection, then we can collect enough the knowledge and the raw data required for this scenario. And then for the phase 2, then we can curate it into knowledge, and then we can train our context specific more. And for phase 3, we can develop into the current workflow. For example, before using LLM, so in each site, maybe we have multiple nurses that can handle that much queries. But now we can have one nurse that just hanging around and then just handling those alert response. So one nurse that can take care of multiple sites. And finally, after the deployment, and we can just keep updating our knowledge because some scenario or some principles can change. And then we are also working from some relatively simple reception scenario to more complicated context in our future work. So at large is I have to I'm very honored that that's I think is the best part of my life. It's like I can working with very talented and very nice person like the people in our lab and also changes the co-correspondent of this paper and providing very professional and technical guidance to the slide member. And we have a postdoc that NIH that's the first author of this paper. And also we have our clinical collaborators, they helping us to collect the data and also the Shenzhen Center, so they help us to organize and conduct the RCT. And we have like supported by Chinese-based fundings. So that's all my presentation. Thank you so much.
Thanks, Dr. Lopez, wonderful job. So, I may ask a sharp question. So first of all, are all patients aware that their conversations will be used for large language model training, even if it's de-identified? The second one is, so you fine-tuned using GPT 3.5. And as far as I know, OpenAI will keep all the parameters models themselves. And okay, and Chinese government blocked ChatGPT somehow. And so in the future, are you planning to train those data with more like local open sourced large language models? That's my question.
Yeah, yes, thank you. Very two important points. So for the first point, so we obtained the patient concept, also called RCTM before collecting data. So we obtained the patient concept. The second part is for titanium, yes, you now GPT so they have things. So currently we are using ChatGLM, so that's a Chinese based and a local word. So for future use. Yeah, very good point. You're saying for those like unsafe or uncertain response when you deploy, so how could we handle that, right? So we have like a multi-turn alert system. Once the alert is coming, so we have a feedback system, so they can be like telling back, so like a reflections and telling the LLM to regenerate and do free again for 3 times. Even 3 times if they don't pass. So we have the final alert. So final alert, so they will tell the nurse, and the nurse will collect that. They'll correct that. But it will be like some like negatively. Like, so they are just actually the safe response. Then nurse just they just confirm. So they don't have to make any correction. So that's all. But we're trying to make this to be more like sensitive. We can involve like human just be confirmed, but we don't want to neglect any like unsafe response.
Internet connection, because that's like that method of having patient conversations. So employee then build ethics to share their conversations. So how to protect the privacy in this process.
Yeah, so that's very important point as well. In this study, we're trying to make sure so all the privacy is being handled pretty well. So we work for them handling. We remove all the personal to be identified information just manually to remove all this out to make sure we don't have any linkage. But that's something like require too many efforts. So for future deployment, maybe we should apply some automatic framework to remove them. Then people just be confirmed. So that's maybe more practical.
Yes, and consider the federative learning to combine the knowledge from different sites.
Sorry.
And consider the federative learning to.
I see. I think that's very interesting direction that we can go because we have multiple centers and you can notice even though so they are very highly loaded, but their patterns are different. So that means that there are space to explore.
Basically, this is a virtual nurse, right? So there's a company I mentioned to you guys, like a Hippocratic AI. They have the virtual nurse in the US, $7 per hour, different roles of nurses. So I don't know if a hospital subscribe to that, but you may check it out. It's kind of, so you have commercial values, like they have different names of the nurses, like Mike for this kind of disease area, and right now US had a problem about lack of nurses. Like those shifting nurses earn a lot, like $100 per hour or something like that. The hospital paying a lot for the nurses.
Is it tax-based or VR like?
I don't know. I haven't tried it out, but you can check it out online. Hippocratic AI, I think. Hippocratic AI. $7 per hour compared to $150.
I have a question. So the real nurse actually can see patients, like if they have bone fracture, they cough, their face is blushed. But here, the virtual nurse can only have text information. Do you think that's a valuable future direction to incorporate multimodal stuff?
Yeah, yes, that's definitely a very interesting point. So yes, so that's one of the limitations that we have. So we are all text-based. So definitely we're working on multimodality LLMs to like try to incorporate audio and also even in the future. So we can capture the video-based information. Definitely very interesting.
Sense. I think now it's time for food.